Hey everyone, and welcome back. I am absolutely thrilled to have you here today for a rapid, highly factual teaching session. We're zeroing in on a really critical, fast-moving situation, the May 2026 Ebola crisis. We're going to break down the complex data, map out the global response, and give you the exact facts you need to understand this outbreak. Whether you're a member of the general public wanting to understand the health implications, or you're a frontline healthcare professional looking for the latest clinical data, we've got you covered.
I want to start right out of the gate with this number, 471. As of the first week of June 2026, there are 471 confirmed cases of Ebola across the Democratic Republic of the Congo and Uganda. And this isn't just some distant statistic. It represents a rapid, highly concerning escalation in a really complex region. The virus is moving fast, and the global health community is quite literally racing to catch up.
Okay, let's dive into this. Here's our syllabus for today. First, we'll cover the 2026 global scenario. Second, transmission and public prevention. Third, we'll pivot to a clinical focus on the Bundibugyo strain. Fourth, medical management and therapeutics. And finally, post-Ebola virus syndrome.
Act 1. The 2026 Global Scenario. Outbreak in Central Africa.
Right now, the absolute epicenter of this crisis is the Ituri province in the Democratic Republic of the Congo. And this is wild. It actually marks the DRC's 17th Ebola outbreak, popping up just 5 months after their previous outbreak in the Kasai province ended. Looking at this factual snapshot, you can see exactly where the cases and fatalities are geographically concentrated. Out of the 471 total cases, the vast majority, 452 cases and 82 deaths, are in the DRC, which gives us an 18% case fatality rate, or CFR, over there. Meanwhile, Uganda is dealing with 19 cases and 2 deaths. So, in total, as of early June, we are looking at 84 confirmed fatalities.
So you might be wondering, how did this escalate so fast? Well, the timeline tells a pretty intense story. Local medical workers actually believe the very first suspected cases might date all the way back to January in Rwampara, but the major alarm bells didn't go off immediately because standard tests were looking for the Zaire strain of the virus, so those initial samples kept coming back negative. This virus is incredibly stealthy when it mutates. It subtly shifts its genetic footprint. It wasn't until May 14th that testing specifically confirmed the Bundibugyo strain, and just 2 days after that, on May 16th, the WHO officially declared the outbreak a public health emergency of international concern.
Now, managing an outbreak is never just about fighting the virus itself, is it? It's about the environment. And the contact tracing and containment efforts here are facing massive logistical hurdles. The region is experiencing active armed conflict involving groups like the ADF and M23, which drastically restricts humanitarian access. On top of that, there are already 1.9 million people in the area who desperately need humanitarian aid. Throw in international border closures and shifting global health funding, including reported reductions in US and WHO capabilities on the ground, and you have a highly complex operational theater.
Moving right along to Section 2, Transmission and Public Prevention, Protecting the Community.
If you're a member of the general public, here is exactly what you need to understand to stay safe. First and foremost, the Ebola virus is not airborne. I repeat, it does not spread through the air. Transmission requires direct contact with infected bodily fluids like blood, sweat, or vomit, or contact with contaminated objects, which we call fomites. The virus enters the body through mucous membranes or broken skin. And because it requires that close direct contact, the people at the absolute highest risk are frontline healthcare workers and the close family members caring for the sick.
Knowing exactly how it spreads tells us exactly how to prevent it. Community awareness really is the absolute first line of defense here. The basic barrier methods and sanitation protocols are crucial. Avoid direct contact with infected individuals, practice rigorous, regular hand washing with soap or lipid solvents, which basically means your everyday alcohol-based hand sanitizers or strong household detergents. Also, you've got to avoid handling and consuming bushmeat and strictly adhere to safe burial practices, because the virus remains highly contagious even after a patient has passed away.
This sign from Doctors Without Borders captures the essence of the public response perfectly. All together against Ebola, always remain vigilant. Community engagement isn't just a buzzword. It is the fundamental mechanism for stopping transmission. You literally cannot fight an outbreak without the trust and cooperation of the people living right there in the affected communities.
Which brings us to Section 3, Clinical Focus on the Bundibugyo Strain Frontline Virology.
All right, we're shifting gears now. For all the healthcare professionals, researchers, and clinicians tuning in, we are facing a harsh medical reality. We are dealing with the Bundibugyo Ebola virus, and this brilliantly illustrates the core issue. If this were the Zaire strain, we'd have an arsenal of FDA-approved treatments ready to go, like Inmazeb and Ebanga, which were monumental breakthroughs. But for Bundibugyo, right now there are 0 approved specific vaccines and 0 approved specific medicines. Our medical arsenal was built for a completely different enemy, leaving us highly exposed.
Section 4, Medical Management and Therapeutics, the Race for a Cure.
So, for the clinical audience on the front lines, let's look at the immediate medical protocols and the fast-tracked pipeline for new countermeasures. On the vaccine front, the WHO actually recommends against using the existing Ervebo vaccine. It's highly effective against Zaire, but there is very low evidence that it provides cross-protection against Bundibugyo. It's a really frustrating limitation of our current viral vector vaccines. But, in response, CEPI, the Coalition for Epidemic Preparedness Innovations, has injected $61.8 million to fast-track 3 new vaccine candidates from IAV, Moderna, and the University of Oxford. So the race is officially on.
Without a literal silver bullet, immediate therapeutic management has to prioritize rigorous supportive care, specifically maintaining vital signs and pushing IV fluids. While we know monoclonal cocktails exist for other strains, they face major systemic stockpiling issues outside of endemic zones. For Bundibugyo specifically, the WHO is recommending immediate clinical trials for targeted therapies, primarily MBP-134, Maftinavib, and the antiviral remdesivir. These trials are our current most viable path forward for actual targeted treatment.
Section 5, Post-Ebola virus syndrome, the long-term clinical reality. Now, what's really interesting about this next slide is how it completely reframes patient care.
We have to look past the acute infection phase and prepare clinicians for the aftermath. Drawing on recent data published by CDRAP analyzing the 2020 DRC outbreak, look at this startling statistic. 86.7% of survivors experienced long-term health effects, almost 87%. Survival is truly just the beginning. When an outbreak officially ends, the clinical burden absolutely does not.
For the healthcare professionals managing long-term outpatient care, these are the specific sequelae you absolutely need to target. 61.7% of patients experienced neurologic symptoms, and nearly 50% experienced musculoskeletal issues, alongside ocular complications like uveitis and severe fatigue. And crucially, the data reveals a really surprising clinical fact. There's actually a higher incidence of these specific neurologic and musculoskeletal sequelae in patients who are treated with advanced antibody therapies, like Regan-EB3 or Zamap, during their acute infection, as well as in older survivors and those with comorbidities.
We've covered the global reality, the public prevention steps, the clinical virology, and the long-term aftermath. But I want to leave you with a provocative thought to chew on. With stockpiles of existing treatments largely held outside of the endemic zones, where these outbreaks actually happen, and with currently no approved tools specifically for the Bundibugyo strain, how can the global health community ensure true equitable readiness before the next mutation strikes? It's an urgent question about fairness and pandemic preparedness that we all need to be asking. Thank you so much for joining me for this explainer. Stay vigilant and keep learning.